Um, Hi, everyone. I'm so sorry that couldn't do this presentation yesterday, but I hope you all understand. So at the moment, there's no fiber where or fiber line is down, so I'm busy using mobile a mobile internet. So I have to sit in an area of the house where it gives me sort of the best reception. So if you hear my children in the background, please don't be alarmed. And in fact, they're sitting, my big son is sitting with me, also trying to understand respiratory acidosis. So we've covered quite a few aspects of acid-base imbalances, and this is the next one. This will be the last teaching session for 2025 because most people now are heading into the busy season at their emergency departments, and most of the students are on holiday. So most people are not really trying to learn at the moment, but just work or relax. So hopefully we'll pick up again in, I'm saying it's the last one of 2024, and we'll pick up in 2025. And yeah, let's get into it. So since we are discussing it, let's go through a patient scenario that we may have. So we have a 65-year-old male patient who presents to our emergency department with a history of COPD. Now, remember, we are going to look at the blood gas just now, but essentially, when you have respiratory acidosis, what it means is that you have hypercarbia. So you have an excess of carbon dioxide. So there's a few reasons for that, and that's what you've got to think about immediately. Why would a patient have respiratory acidosis? So anything that causes the patient to keep carbon dioxide in their body will be a reason for respiratory acidosis. So COPD is, of course, one of them. You may have, for example, a decreased, respiratory rate, nervous system problems, and other lung diseases that may lead to it. But let's have a look. We'll go through all the causes in a second. So he arrived after experiencing an acute exacerbation. So, shortness of breath, wheezing, and fatigue. And the main change is that he's become sleepy and less responsive than normal, which is the body's normal response to acidosis and to any changes in your acid-base balance. It throws a person's it throws your homeostatically, if I put it physiologically, it throws you off balance to a great extent. So one of the main things that happens is that you do become drowsy, sleepy, things like that. And it also has to do with blood delivery to the brain, with vasospasms and things like that. So the patient admits to struggling to finish a sentence without gasping for air and complains of a severe headache because you can get cerebral edema sometime with this as well. So he's known COPD, diagnosed 10 years ago. He's hypertensive, currently on corticosteroids, bronchodilators, ACE inhibitors for hypertension. He's a former smoker with a 20-pack year history. And just remember, if you're not sure how to work out pack years, on the ED Assistant website, I've got the pack year calculator there for you, so you can go through it and work it out. So even if you had only smoked for 7 years, but if you had smoked enough cigarettes, you may have a 20-pack year history, or you could have smoked for 40 years, but by smoking less cigarettes a day, it may only be a 20-pack year history. So pack year history basically tells you, it gives you an idea of how much of damage has been done to the lungs. So that's basically where we go from there. It has its own connotations and that, but we won't get into that right now. So it is slightly hypertensive, systolic hypertension, tachycardic, he's tachypnic as well. And you can see his sets are a bit on the low side, but actually for a COPD patient, we should try and keep them between 88 and 92, but we'll get to that just now. So general appearance, drowsy but rousable and using accessory muscles for breathing. So somebody is struggling to breathe and who is now presenting with a slightly decreased level of consciousness, and of course has signs of an acute exacerbation of COPD. So let's go through the ABG itself. So the pH 7.28, so it indicates your acidosis. It's showing you that he's in an acidosis. And of course, we go immediately to your PaCO2, which tells you how much of carbon dioxide there is, and it is elevated above the normal. So the hypercapnia or hypercarbia, is now telling you that, he's acidotic because of a respiratory cause. And he's got a compensatory increase in his bicarb. So his bicarb now is being retained in order to try and combat the respiratory side of things. Now, this in itself takes quite some time to happen. So it shows you that he's been ill for quite some time. And then he is a bit hypoxic as well. So he's got a combination of respiratory failures. He's both got respiratory failure type 1 and respiratory failure type 2, but we'll get into that as well. We've got it shown in another slide. So what are the causes of respiratory acidosis? So like we say, anything that causes your body to, or makes it difficult for your body to get carbon dioxide out. So the first is anything that causes airway obstruction. So asthma, COPD, as in our patient, central nervous system depression, so any sedatives, head trauma that is causing a patient to be bradypneic and not breathing as quickly as normal or within the regular or normal rate, and that's when you would expect that. Then some neuromuscular disorders such as myasthenia gravis, Guillain-Barré, but those of course have their own symptoms that come along with them. The respiratory acidosis is just part of it and is often seen sometimes with lung disease, such as pulmonary edema and severe pneumonia, although not as common, but it does happen. And then other causes, of course, obesity, hypoventilation syndrome, chest wall abnormalities. Again, anything that prevents your patient from breathing normally is going to lead to an increase in carbon dioxide in their system and hence respiratory acidosis. So what are the symptoms and clinical presentation generally that we see? So in this case, shortness of breath, confusion, lethargy, somnolence. Somnolence, of course, referring to, uh, sort of the patient being arousable, but, sort of like sleepwalking, that's basically what somnolence would refer to. And your chronic symptoms would be fatigue, headaches, sleep disturbances, and then daytime somnolence. So all of these have to do with the changes that take place in the central nervous system with the increase in carbon dioxide. So once you have this increase in carbon dioxide, you sometimes get a vasodilation that occurs, and sometimes a reflex vasospasm that can also occur. But basically what happens is that it generally leads to a cerebral edema. Sometimes, depending on the exact cause, you can also get what you can call it cerebral cell shrinkage, which can also cause some of these symptoms. And in severe cases, eventually, then that shrinkage or edema, depending on the precise cause, can, of course, cause altered mental status, hypotension, cyanosis, coma, and eventually death if the patient is not treated. So the management of respiratory acidosis is quite easy. You need to get oxygen in and get carbon dioxide out. And the easiest way to do that is to ensure that you have a good airway. So that's where this comes in. So you ensure your airway is patent and that you have proper ventilation. Now, proper ventilation could mean assisted ventilation, CPAPs, BiPAPs, any of those, invasive, non-invasive, as mentioned over here. You can, of course, give oxygen therapy as well, by administering oxygen. The problem with patients who are having COPD is that their body is actually used to having a lower SATs, a lower SpO2 and a slightly higher carbon dioxide level. So that increase in carbon dioxide is actually stimulating the midbrain to get them to breathe. So that hypercarbia basically is telling the midbrain that, listen, there's too much of carbon dioxide. You need to keep on breathing. And there's too little oxygen. So you need to, continue to breathe. The thing is with COPD patients, especially because it's quite chronic, once you take, now remember that's it's a reflex mechanism. It's an adjustment mechanism. The body has adjusted to the COPD. So once you give them too much of oxygen and you take out too much of carbon dioxide or take it out too quickly, there's no stimulus for them to breathe, and they can actually go into respiratory arrest. They can actually deteriorate quite quickly. So for your COPD patients, it's best to keep, especially your severe COPDs, not your mild COPDs, but your severe COPDs, moderate COPDs, you're trying to keep them between 88 and 92. So, that's the sats that you're really looking for. And once you get them above 92, you must understand that you're getting them into danger. And if you've got them below 88, then it means that you're not giving them enough. So that's an important thing to remember, especially in the emergency department. We often feel that we need to get our sats as close to 100 as possible so that we know our patient is okay. But in this case, especially with COPD, you need to make sure that you're getting your patient into a state where they are between 88 and 92. So you can do this with CPAP, BiPAP, and some of our hospitals do have this, even in the public sector. In in the private sector, of course, it's freely available. And invasive ventilation only if there's severe respiratory failure. You wouldn't rush to go and intubate these patients unless they're really, really struggling. So you try and treat the underlying cause, such as in asthma. It's difficult to treat COPD chronic, but of course you can still give them bronchodilators. When I say treat, what I mean is you're not going to reverse the COPD, but you can at least improve the exacerbation. Give them steroids, antibiotics if you have an infection. Sometimes if they have sedative overdose, then you reverse the sedatives. It just depends what you need to do. And of course, neuromuscular weakness, supportive care. And of course, you treat specific things like Guillain-Barré can be treated and things like that, So you're going to treat as you can. So how do you monitor and follow up? These patients keep on repeating your blood gas to make sure that your pH is starting to rise and getting closer to normal, to see that your CO2 is decreasing. You're not going to see much of a change in your bicarb in your emergency department because that's going to take about a day or so to actually rectify itself. Keep an eye out for your lactate as well, especially if your patient is very hypoxic. Even though I've got another presentation that we'll do next year on lactic acidosis, but remember, lactic acidosis could also be contributing to that. And sometimes if they have a very high lactate level, they may initially actually get worse before they get better. So, there's a few things that go along with that as well. And you're just going to keep an eye on the patient and make sure that they don't deteriorate. And one of the things that causes deterioration, like I say, especially in COPD patients, is giving them too much of oxygen as well. So you need to be careful of that. Of course, your long-term care, your pulmonary rehabilitation, so physio, regular checkups with a pulmonologist or physician to make sure that they are being treated if they have TB, if they have underlying asthma. In these days, even long COVID, there's a lot of things that could lead to this. So, but just wanted to give you guys this. It's a nice thing to take a screenshot of if you want to. It just gives you the difference between type 1, which is hypoxic, and type 2 respiratory failure, which is hypercapnic, or hypercarbic, depending on what terminology you use. So our patient had features of both. He was both hypoxemic, so he had low PaO2, and he had high PaCO2. But anyway, in this case, the respiratory type 1 generally has a low oxygen, but with normal or low carbon dioxide. So our patient, even though he had the low PaO2, but he didn't have the low carbon dioxide, so we would look at him as a type 2 likely because he has low oxygen, but elevated carbon dioxide. So he's really a type 2 respiratory failure. The primary issue with type 1, of course, is failure of oxygen exchange. So oxygen is either not getting into the lung or it's getting into the lung but not getting into the bloodstream. So that's where the issue comes about. This is when they talk about VQ mismatches and you do VQ scans and things like that, especially in patients who have it for a long term. And type 2 respiratory failure, like I say, is failure of ventilation. So your patient is unable to get rid of carbon dioxide. They're unable to breathe properly. So the causes of type 1 generally are pneumonia, things like pulmonary embolism, pulmonary edema, acute respiratory distress syndrome, where the oxygen is unable to get either into the lung or unable to get into the bloodstream, or like in a case of pulmonary embolism, the blood is unable to get to the lung. So these are the causes. Whereas with type 2, you're generally looking at COPD, neuromuscular disorders, as we mentioned, chest wall deformities, obesity, hyperventilation syndrome, that whole list that we went through. And like we see, the PaO2 is decreased in both, But in type 1, you have normal carbon dioxide, Ca or PaCO2, but it's elevated in type 2. So that's the way to remember it. It's something very often, especially when you're on your rounds in medicine, in the emergency department, something that your seniors and your consultants may ask you, to define the two types of respiratory failure, because the way that you treat them is a bit different as well. And in terms of pH, generally your type 2 is acidotic, whereas your type 1 is alkalotic to normal, and this is due to hyperventilation often, So if you're one of those, I know when I was a younger doctor, I used to struggle a lot to remember this. I used to struggle a lot to remember a lot of things. But this is one of the things that once you get it into your head, it's quite difficult to forget as well. So it's a good thing to remember. And this is just the end of our presentation. So as we know, we give all of our patients with COPD a good amount of steroids, and then their pancreas very happy as the stomach lining is busy screaming at us. So I hope you guys learned something. Thank you for those who are watching this later on. I suppose with the change in date, nobody had joined live. But if there are any questions or if there's anything that you would like to know, you're more than welcome to message me either on the group or via the comments in YouTube, or even privately. It's not a problem. I'll try and answer your questions as best as I can. So the most important takeaway from this is understand that your patients will have a increased PaCO2. They'll generally be a type 2 respiratory failure. You can try and get oxygen into them, but also get carbon dioxide out. So you need a good airway. And in your case of your COPD patients, you make sure that they are not given too much of oxygen, so as not to stop their respiratory drive as well. So those are the takeaways from this, and I hope you guys enjoyed it, and I hope to see you all next year again, and that we can do more teaching in that time. But enjoy the rest of the season and enjoy the leave for those of you who are on leave. And for those of you working in our busy emergency departments, I wish you all the best, and I hope it goes well. Thank you very much, everybody. Keep well. Bye.